Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Welcome to the Rehab and Performance Lab, where we have conversations about bridging the gap between research and real-world applications. And you get CEUs too, so that's great. I'm Phil Plisky, your host. I'm a professor and author at philplisky.com and a consultant in professional sports. Being a physical therapist, an athletic trainer, and strength and conditioning coach, I come at this from many different perspectives. We want this information to be research-based, but also, most importantly, practical and useful for you. I'm excited about our topic today, returning to running after an injury. And to have this discussion, I've got Dr. Todd Arnold, who serves as the medical officer for elite athlete care at USA Track and Field. And he might kill me for this introduction, but one of my favorite job descriptions for him is that he makes the fastest people in the world faster. That's what his team does. He's part of this team that gets to go do that. Welcome, Dr. Arnold. I'm so glad you're here.
Thanks for having me, Phil. Looking forward to it.
Fantastic. Just by starting off, could you tell me a little bit about what your team does with these Olympic athletes? Meaning you've been involved in at least the past 3 Olympics where our USA Track and Field team has done really well, probably most medals ever. Could you tell me what your team does with these athletes?
And so you're right. I've been involved since before the 2012 games in London. And the team that we put around athletes is really actually pretty cool. I go as what I would describe as a self-proclaimed movement geek. I believe in how the human body should move. And then I take either a physical therapist or an athletic trainer with me on the road, and then a biomechanist specific for that sport. We have biomechanists that for javelin, and we have them for sprinting and hurdling and high jump and stuff like that. And then a lot of times we also take a sports dietitian and a sports psychologist with us, and we rally around those athletes, and we see the elite ones every 6 to 8 weeks, so that we can be around them and first see how they move and then put them on a table and make sure that they have symmetric joint mobilities and symmetric, strengths where they need to have strengths, and then really specific things like javelin throwers need to be able to do something really specific with their thoracic spine. And then we give them to the biomechanist. So then the biomechanist can say, okay, now let's teach them this drill that can help them throw the implement further. And then the whole time they're also there with the dietitian to make sure their nutrition is up to snuff. And then the sports psychologist is probably there to unpack most of what we tell them is wrong with them. So it's this team that rallies around these athletes. And sometimes we go that many people just to go see one athlete at a time to try to fine tune their skills.
That's fantastic. So what's really cool is you're both on the performance aspect of things. So fine tuning that race car so that it can get a 100th of a second faster, which is literally the difference between a podium and not, right?
Right.
And so you do it at the performance end, but also not all goes as planned with these folks too. So you're a little bit working on the return from an injury or working with a nagging injury as well.
And that's part of the elite healthcare process that I do, is as I serve as the physician for those 160 funded athletes to try to keep them healthy. But then when they do get injured, then I'm a part of the process of trying to get them back and trying to find a way before that next big event or before they need to race again so they can be competitive.
That's so awesome. I know a lot of people are very jealous of your job. With that said, certainly comes a lot of travel. Tell me how you initially got into the kind of this field and the interest in athletes and things like that.
Yeah, I think my path is pretty similar to a lot of people. I grew up in an athletic family. I had a sister that was a 3-sport athlete all the way through high school. My dad was a coach before he passed away when I was young. And so I just kind of grew up in an athletic family. And then unfortunately, like most of us, I got hurt and I had a pretty substantial injury that held me back. And I had someone work with me that helped me get back to one level, but not the level that I was back to or that I needed to get back to continue. And I was enthralled by it. I loved that person and I loved what he did and I loved how he was invested in me as an individual. And that blossomed into going to medical school and then doing a fellowship in sports medicine. And then, as I kind of alluded to at the beginning, becoming a self-proclaimed movement geek, applying it to this process of performance health.
Oh, that's awesome. And I think I like what you bring in there is how we get to impact people's lives, how we get to serve them, how we, hit them both at their peak when they win, and also that at kind of their lowest times when they don't even know if they can compete in their next thing that they've been working on for 4 years. And we have a really great opportunity there. Now, we're talking about return to running today, and it is, I think, is probably one of the more difficult, more complicated things that we do, and how to do it. Why do you think we should be asking this question? Like, why is this important?
That's such a poignant question, Phil. I think it's because for so long, what we've done is we've just thrown spaghetti at the wall and decided that if it sticks, then it's done, kind of thing, and that doesn't work for runners. It doesn't work for my population that's elite, and it certainly doesn't work for my population when I worked in the clinic, where I was taking care of a bunch of me's, a bunch of people that were like me that just wanted to run a half marathon or run a 5K, and it just doesn't work because you can't throw that up there because every athlete's different. The variety of injuries is so diverse. It might be IT band syndrome, it might be a tibial stress fracture, it might be some really bad stress fracture like a navicular stress fracture or sacral or something like that. And then you have to also consider what they're trying to get back to. So there's so many variables. If you just kind of go, yeah, this is what we do, that doesn't work like that.
Absolutely. And we're dealing with all different types of people too. Like we're talking about running, but that doesn't mean just runners, right? Like that it does not mean people who jog and all that. Like pretty well every sport involves either running in the sport or running to train for the sport. So this is a pretty big and diverse population that we're talking about, and from spanning the spectrum of young kids all the way through what would be geriatric adults. So it's a lot of people, and it affects a lot. So can you give us an idea, the highlights of the research on return to running? Because there's got to be a ton of research on it, right? It's so pervasive. It's such an important topic. This has got to be expansive, right?
It's got to be, but it's not. Yeah, it should be. For the running world that I'm talking about today, there's not a great deal of research. There's lots of opinions and there's lots of good, pathways that people have designed, but really the bulk of the research comes from really specific injuries and reconstruction surgeries that they can then quantify and move forward. And I think it's just because there's probably more investment in those processes, not necessarily those people, but more investment in the process to get those people back. And most of the research is really done around ACL reconstruction. It's something that we know, and you can say we put this ligament in and it was done on this day, and these are the hallmarks and these are the benchmarks that we have to be able to make before we can go back to run. But there's not a ton of raw research and blinded studies where it's two stress fractures and we tried to determine which was the better way to get people back.
Right. Yeah. So we're not seeing these double blind randomized controlled trials of these return to running programs for even a specific injury, even ACL reconstruction. It's a little bit, it's more like this is what we did rather than this is what is the best. Is that right?
And yeah, and that's exactly what the research in the ACL reconstruction looks like. Is they've gone back and they said, okay, here's some things that we can look at. We can look at limb asymmetries, and there's an index for that. And you can look at lysome scores, and you can look at hop testing, and you can do these types of tests to assess if people are ready, and look at their whole body movements to make sure they don't have some horrible asymmetry that was set up by the crutches or the non-weight bearing status and things like that. And if you can identify some dysfunctions in those, then it's time to hold those people back. But it's also very much dependent on time. A lot of the researchers say that you should just wait this number of months. So you should wait 4 months. And then if you have this hop test that's symmetric with your non-involved leg, and you've got a score that's like this, and your symmetry is here, then it's time to start running. And that's good research. And it gives us a really good backbone for us to move forward with those people. But that doesn't help us when people are getting back from an IT band syndrome and maybe only missed 2 weeks.
What are those in your analysis of the research? What are those biomarkers that you would say from a limb symmetry index perspective? Like, what are you looking for that, is going to say, all right, after an ACL reconstruction, since we have the most robust literature there, what are those biomarkers that we're looking for?
Yeah, and so a lot of the things are, pure strength. What's the quadricep strength? What's the hop test? What's the Y balance test? What's their movement pattern? What are their, objective numbers that they can look at? But a lot of it is really focused on strength, which then becomes hop testing.
Yeah. So we're hype testing, we're isokinetic dynamometry, that type of thing. So how do we translate this research into the clinic? How do we go from, hey, we've got some stuff that we look at, to then there's this person right in front of us that we've got to say, hey, this is how I want to get you back to running.
And so that's where I think that's where the magic comes in. And what I think people can take away from it is that it's this: you have to take into consideration who's sitting in front of you, the athlete that is there, the severity of the injury. Is it a risky injury for something that, if we don't do this right, they're going to end up with something potentially very bad, something that's going to change their life, maybe become a surgical fracture from something that was an early stress fracture. You don't want to ever make those steps. You definitely want to be able to say, is this a growing and maturing athlete? Because you're going to treat that person differently than a 25, 28, 30-year-old runner that's maybe doing the same event. They're just doing recreational running for fun because that's what their family does. But a 30-year-old person with a stress injury is different than a 14-year-old, immature athlete. I also think you need to measure people's tolerance risk. The athletes that I am blessed to take care of, they definitely have a higher tolerance to the risk. I would not have that as an individual runner. I would not have much tolerance to that risk, and I wouldn't try to cut any corners, but the elite ones will. Another variable that has to be considered is, what kind of fitness do they have? Were they really fit coming in? And because that will change the path that we have to take moving forward. It'll change the path that they take as an individual. And then what other things can we be working on? So I hate to shut people down. It's one of the things I tell my athletes all the time is, I know you don't want me to shut you down, so we're going to find all these other things that can work on, maybe why we got here. Their hip wasn't extending well and it's making them strike really hard on their opposite leg, or their glutes not firing, or their dorsiflexion on their ankles off. What other things can we be doing? So I try to take this really complex set of variables and say, who's my athlete? What kind of risk tolerance do they have for the severity of the injury? Are they young? Are they old? Not old, but are they an adult? And then, how much fitness did they have coming in? And then I think we can really maximize their process going forward to try to make them a full runner again at some point in time.
You said something that I think really needs to be highlighted, maybe dug into a little bit deeper there, is, the concept of shutting down a runner or shutting down an athlete. I don't think there's anything worse that you can say as a provider to those folks. Yet sometimes it's necessary. One of the things you said in that was, we're not shutting you down, we're doing different things. I think that's actually a subtle but a very important distinction that these athletes need to hear from you as a provider, that we're not shutting you down. We're working toward your goals. Just maybe we're on a little bit different path and going from there. How do you have that conversation? How do you decide, first of all, how do you decide that I'm going to shut someone down from running for a week or two, or however long? How do you decide that? And then how do you have that conversation?
Yeah, and so some of it is just the severity of the injury. If you have an MRI scan and it's a high-grade tibial stress fracture, that person's going to have to stop running for a bit of time so that the bone can catch up to the overload that it's seeing. So some of it is just physically, what does the scan show, or what does the X-ray show, or what's the diagnosis? The second is, what their risk tolerance is. If they say, I'm willing to do this and take that risk because it's just pain, IT band syndrome hurts and it's really high quality pain for these people, but they're willing to go through it, I'm willing to not shut them down. But you hit on the really you really hit the nail on the head hard when you said that talking to them up front about that is just one of the hardest things that we do. Runners like to run. Athletes like to be athletes. My golfers like to golf. And if you have to tell them not to do it, then they don't like you very much. And then maybe they don't listen to you very much. And so I do think that you kind of alluded to it a little bit, that the answer is to say, yes, I'm going to take you away from running for now, but I'm going to replace it. And I'm going to replace it with these types of things. It might be this dysfunction that we found that maybe set you up for it, but it will also be a very detailed discussion of, here's the plan to get you back to running. I start that discussion on the first visit when we have to shut people down. We've identified what their goals are. If their goal is to run the 5K this fall, that's a different answer than if they need to run in the trials in June. And so when we sit down on that first day, I make sure that they know that I understand what the calendar is and that we've outlined, here's the end goal, here's the starting point, this is what it's going to look like. And I've tried to outline that for them. And I think that makes all the difference in the world.
So really working backwards. So just really kind of mirroring back to them both their risk tolerance, hey, if you do this, we might not get this healed, right? And that if that's worth the risk to you, because again, you've been training for 4 years, the trials are here. If you don't make it, like have to wait 4 years, and you kind of might age out at that point in time. So this might be your last Olympics. Or, we're dealing with the recreational runner who we're saying, yes, I want to run in the race that is 2 months from now, but do I need to run in that race? Or would I rather be perfectly healthy for a race 2 months after that? And mirroring that back, that risk tolerance there. And then also beginning with the end in mind, saying, okay, well, now if we agree that we're going to go for our next race in 4 months, that means 2 weeks before that 4 months, you need to be running this distance. 4 weeks before that 4 months, you had to be running this distance, which means now we keep working back to today, which means we have 2 to 4 weeks to do these other things that don't involve running, and you're still going to have plenty of time to do what you need to do to feel great in your race. And I think that's an important thing.
You've given them that chance. You've afforded them the opportunity to say, oh, that's great because I hit the mark. But 2 weeks of rest isn't going to set me that far back. Yeah, exactly.
Yeah, that's an important thing because 2 weeks of rest feels like an eternity to any athlete. And now this has been great theory. I love talking about the research. I love kind of figuring out, okay, there may be these markers we can kind of use. But do you have? Can you think of like some cases of specific people that like we can go through so that you can kind of make give some clarity to this? Like let's walk through a case.
And so I don't have one right off the top of my head, but I'll kind of make one up that is just super common. A young 20-year-old female that's got a tibial stress injury and she's training for a half marathon. So, I probably in my clinic would see, I don't know, a dozen of those every spring because there's a local half marathon and we would see those all the time. And then we would have to make a decision if we could make that half marathon in May or if we would then have to, scrap that and go for one in the fall. So they've got a medium grade stress injury of their tibia, pretty safe bone, not a high grade injury. So you're pretty comfortable allowing some things. And so the first thing that you have to make a decision of is, are you going to immobilize them or not? And so, a tall boot on a tibial stress injury is something that we will use if people are hurting while they're walking around. If they just have daily life pain, they probably need just some support, maybe for 7 or 10 or 14 days at the most, but we have to kind of get control of it. Think about just having a burn on your finger and putting some ice on there really quick. It just kind of turns the fire down so that maybe the extent of the damage doesn't continue. But during that period of time, we've had the initial consult, we've looked at the MRI scan, and now I've told them, hey, I think I can get you back. We're not going to shut you down for, 2 months and ruin the May race because it's only January. And I think we can get you back. So that first 2 weeks, we're starting to work on some fitness things. We're maybe using some arm bike. If they have access to the pool, we'll use that. But not everybody has access to those types of things, either in the clinic or certainly they're not going to the gym because their gym doesn't have a pool kind of thing. So I think the thing at that point in time is I outline what I think they should be able to do. The typical progression that I take that recreational runner through is I'd like them to be able to bike and followed by some elliptical, which is weight bearing, and then we can get them running over the ground. The goal is to get them, tolerant to the weight bearing process of the elliptical.
One of the things I've found with this process, because we're describing it as a process, we would love to describe it as a protocol, right? Like that that at week 2 you are definitely doing this. But one of the things let's say we do have to put someone in a boot, or we do have to substantially, we're changing to a non-weight bearing cross training type of activity. One of the things that make athletes is having goals, having something to shoot for. And this is where a lot of times I actually just change their goals a little bit for them. So, it might be one of those things where I say, okay, in this next 2 weeks, what we have to focus on is getting your ankle dorsiflexion range of motion to be symmetrical here. And let me show you how I test it. Now, let me show you how you're going to test it at home. And these are going to be the things that we're going to improve. And we have to have this by those 2 weeks. Is that something that you ever do or ever consider in your practice?
Yeah, and so I like those goals, whether it's their ankle dorsiflexion, if we've decided that that's the problem, or it's a certain amount of time and resistance on the bike. That gives those athletes that challenge of saying, well, he says my ankle dorsiflexion needs to increase by 6 degrees, so then I'm symmetric, or my hip extension strength needs to increase, so that now I'm symmetric when I run. Yes, those are the types of goals that I would be setting out for people. On the bike, it's 45 minutes with moderate resistance, and that applies to the elliptical too. And if we can build that around their corrections and in a couple weeks, the next thing you know, they're back on the ground running, and they really never even missed that much time. And their goals and focus was always my ankle dorsiflexion, and I got to get on the elliptical, and then I can be over the ground on the ground in a reasonable period of time.
So I heard some biomarkers in there, and I really like going after biomarkers, because that again it objectivizes it for us, and it gives a goal for the athletes we're working with. I heard 45 minutes at moderate resistance on the bike. That seems to be a marker for you that you want to see that before they return to running.
Yeah, and so, or the progression. So, if they've come from a reasonable amount of fitness, they came in not just starting their running in January for the May marathon, but maybe they started in November or even October. They came in pretty fit. I can say, this is what we're going to do. We're going to start on the bike at 15 or 18 minutes with low resistance. Every day you're on it, we're going to crank up the resistance or crank up the time. And it's just going to go day by day by day. And over 10 or 12 days, you can get up to 15 or 45 minutes from that 15. And then if you've done that and you're not having increasing pain, we can transition to the elliptical, do the exact same progression. And people have been really successful with that in my practice over the last 3 decades.
So what I'm hearing in that too, and kind of maybe in between the lines, and correct me if I'm wrong in reading that, is those people who do this, progressive, cross training, don't seem like they're actually losing any time or any training time, because they're actually keeping their muscular endurance up. They're keeping their cardiovascular, endurance and power up. Is that a fair thing to say?
It is, and a bunch of the research is pretty supportive that it takes about 2 weeks before you lose what I would call measurable fitness. Now, with our elites, you'll definitely notice that, because they're trying to make the difference between, like you said, hundreds of seconds. But in the rest of the world, and even in the elites, it's probably about 7 to 10% that they lose in about the first 2 weeks. So if you can just buy them those first 2 weeks, and then start doing something, challenging their physiologic system by doing some bike with some resistance, and then to elliptical, boy, they're not going to drop back very far. And when they start running again, they'll be so much better off than if they just take 6 weeks off and then start running again. Those people are a disaster. Those people have lost fitness, and then they're going to cycle right back into the same injury.
Right, because they've lost the fitness, and now they're trying to push hard, and it doesn't work
to make up for time. Yeah.
So let's say we get through this early cross training protocol, and they get to the level that you want them to be. 45 minutes moderate resistance, or whatever you have set as that marker. I don't want people to hear that I'm saying that, Dr. Todd Arnold says 45 minutes on the bike, you've got to be able to do that in order to start running again. I think you're giving an example, not a hard and fast number. But once they finish that, then how do you get them back to running? What does that actually, because I don't know. I'll tell you, in my practice, it's always, you gave that throw some spaghetti at the wall and see if it's done kind of analogy. I've got to say, it's felt like that a lot of times.
So the downfall is there's no research in this. So it's going to be my opinion, and it's going to be some other people's opinion that I've, followed online and in other podcasts like this. But I think what works for most people is to say, okay, take a 3-day cycle. And once we're running, we're going to run some number of minutes. And I'm just going to give the example. We're going to run 10 minutes on day 1. And on day 2, we're going to add to that. We're going to run like 13 minutes. Then what we're going to do is on day 3, we're going to take it off. We're going to rest. We're going to cross train. We're going to do our corrections. We're going to do resistance training. We're going to do something else. Then on day 4, we're going to repeat day 2. So we're going to go 10, 13 off, 13 again, because we've already proven that we tolerated that. And then we'll add another 3 minutes and we'll go to 16 and then take a day off. So it's this algebra problem that each day when you add, you just are adding the same number of minutes, and you go 10, 13 day off, 13, 16 day off, and you just build from there. It's much faster than the 10% rule that's out there. I tried to find some research that really supported that. And there's good research that shows that if you increase by more than 30% in any kind of given time frame of about a month, that's when people really fall off the curve, but 10% is safer. But boy, these people will not tolerate 10%. If we start them running at 15 minutes and we add 10% a week, you literally are going to take 12 or 14 weeks before they're actually up to real numbers of running, which is what people want to be doing. People don't want to be running 15 and 18 minutes. They want to be running 30 and 45 minutes. And some people want to be running for 10 hours a day. Those people would take forever to get back to that point if they follow the 10% rule.
Oh, absolutely. And I wish in preparing for this discussion that we were going to have, one of the things I remember, one of my mentors, literally 25 years ago, came and presented a journal article to the clinic, and it was about, I know it was in the American Journal of Sports Medicine, but I can't find it. But it was comparing people who did the 10% rule returning to running and those who just kind of went at their discretion, right? And there was no difference in the at their discretion versus the 10%. And like you say, there is a certain amount of, you've described a 2-year process. If someone's running a marathon and you're starting them back at 10 minutes, like you can't, like that just doesn't work very well. But now, I really like that. I really like that structure that you gave everyone here of this 3-day on off, and we're ramping up very specifically, systematically, but does it always work that way? Does it does every person you work with, they just seem to like do this 2 days on, 1 day off, and you just, increase the second day to be the first day of the second cycle and everything goes perfectly, or what really happens in the real world?
I would love to tell you that yes, everybody's ever worked over 25 years, but that's not true. It's actually not true at each of the levels. And so and this is part of that initial conversation that's so hard to have. I tell people this is going to be the process, but I also mention that you're going to have a setback. I think probably 8 out of 10 of my athletes probably have a legitimate setback where we change something. I always try not to change time or resistance on the bike or on the elliptical, or make too many changes at one time, because then we don't know which variable is causing the problem. But sometimes people, not sometimes, 8 out of 10 times people will have some soreness. They'll get some irritation. The next day they'll start to hurt, and then we have a problem. And so what you have to do is you have to set them up for that setback or failure, to say that's going to happen, but it's not a disaster. And we're certainly not going all the way back to time 0 and shutting you back down or putting you back in the boot or starting over on the bike. We just tell people what you're going to do is you're going to go back to what you were successful at, whatever you did not create pain into the next day. And we're going to do that for several days in a row, 3, 4, 5 days in a row. I just think of it as the hardening process to give them that chance to then break through that barrier. But that happens all the time. The setback happens more commonly than I would like to admit.
I really like that, because there's a couple things that happen there. Is one, it normalizes the quote unquote setback process. And rather than even maybe calling it a setback, it's just part of the process. You're going to hit this point that we will have pushed too far, and that's okay. But what we're going to do is once we find that spot that we've pushed too far, we're now going to go back to where we were successful and stay there a little bit longer, and then restart the progressive process again. So, it really sets them up of, we're going to go to that point. Cause I even think about, I remember learning early in my career that, someone, a rotational sport athlete, for example, if their movement is perfect on everything, like it is just absolutely perfect. I love the phrase of, you're probably not training or trying hard enough, right? Because if everything stays perfect all the time, you're not putting the system at its limit, and causing some dysfunction. Now, we don't want to leave that dysfunction over a prolonged period of times, and that's why we monitor it. But if everything's always perfect, you're not pushing hard enough. And that concept applies here. So one, we've normalized the fact that we're going to push too far at some point in this process. I don't know whether that's going to be at week 1 or week 6 or somewhere in between, but we're going to push too far. And here's how we deal with when we've pushed too far. So it's normalized. Number 2, it also maybe gives a little bit of perspective to the athlete that we are going to be pushing you, and being at the limit is where growth occurs. I mean, that's exercise physiology 101, right? Like unless you stress the system enough, it won't have this super compensation phenomena to be able to get better, and we don't perfectly know that limit. Now, so I love that progression. Are there any other maybe markers that you use during this time? And I'm thinking of, I like to put up some guardrails with my recreational runners. I don't work with Olympic runners, but with recreational runners or my field and court sport athletes, I use some guardrails of both cadence and heart rate. So those are my 2 guardrails. I find that if I keep their cadence above 170, 175, and I don't let their heart rate spike, beyond, an aerobic threshold when we're doing longer distance running. If I don't do that, then we've kind of kept them safe throughout this, quote unquote safe. We lower the risk of injury. Tell me about it. What is there in the research about that, and what is there in your practical experience about, let's take cadence, for example?
Yeah, and so cadence is a really funny thing that, there is research out there that shows that the best economy is kind of in that 160 to 180 range. You hit 170 is where you're at. And there's definitely people that run well in there, but you have to be really careful about that, because if you're taking someone that's just a talented runner, not necessarily the, elite caliber athletes, but just a really talented runner, a fast marathoner, and you tell them to start trying to change their cadence, and that will change their mechanics. These people are strong. Their glutes are strong. Their hamstrings are working well. What they'll do is they'll try to speed up a little bit more. They actually may start to travel a little bit further because they're actually using those muscles, and then they may actually hurt themselves, or go the other route and tell them to slow down. And I hear this all the time that, I hear the questions from people, well, what pace do you want me to run? Do you want me to, do my 10 minutes, my first run really slow? And I say, no, I want you to be whatever is comfortable. And the reason that I've come to that conclusion is that there's pretty good research that shows that the faster you go, if you're an elite athlete, the faster you go, the better your mechanics get. If you're a recreational runner, it's a U-shaped curve. You're not very good when you go slow, and you're not very good when you go fast, but there's a sweet spot right in the middle. And I don't know what that is for Phil. I don't have a way to measure that for everybody. And then if you're a novice runner, if this is the first Couch to 5K program that you've done, their data is all over the place. Some of them are good at fast and some are good at slow, and you can't predict that. So I just tell people, run and be comfortable, because if I try to manipulate them, I may put them into a situation where I'm actually creating poor mechanics, not knowing where they live on the U-shaped curve, or if they're a novice, and I'm going to set them back. To extend that even further,
the idea of that comfortable. And maybe that's what I'm getting at. And again, this is level 5 here evidence. This is Phil talking, having worked, I'm no expert here, but the idea that maybe that heart rate is giving us that quote unquote comfortable, that if my heart rate's not fast or high enough, I'm probably running too slowly. And B, if my heart rate is going into an anaerobic level, then maybe I'm running too fast, right? I think physiologically, our heart rate responds to our mechanical efficiency breakdowns faster than maybe our RPE or even our pain threshold, our mechanical inefficiency will show up in our heart rate before it ever shows up in our mind. What do you think of that?
Well, absolutely. Two things come to mind for that. First of all, research is pretty supportive that distance runners have really high pain tolerances. You can put their hand in ice water and they'll keep it in the ice water much longer than other athletes. And so if they're supposed to be just paying attention to their RPE and how hard they're working, they're going to hurt themselves. It's how we got here, just because they'll just keep doing it. The second thing is you don't want to get them tired. The other part of that research on their cadences and on their mechanics is that if you fatigue them, they will then have bad mechanics. And so that's really important that we go from the 10 minutes to the 12 minutes to the whatever, and we get there, we set those goals, because if we fatigue them, then they'll have bad mechanics, and then we'll end up either with the same problem or we'll create a new one for them. And that is on us 100%. So using that heart rate to say, I'm not fatigued because, Phil said my heart rate should be between these two numbers. I'm staying there. But if I get up in the one, I'm up above that by 10% or I'm up by 20, beats per minute, I'm getting fatigued and I need to shut it down.
Right. Because, I remember early I had a resident once who it was great. She a long distance runner, real high class runner. And she said, my patients, I just don't really understand because they come to me and they say they have knee pain with running. And that really doesn't make much sense to me because, it's running, so it's going to hurt. And I just went, wow, that gave me so much insight into a runner's mindset that well, of course it's running. Like if there was something comfortable about running, everybody would do it. Right.
Right.
So I think I think that RPE and so what I'm really hearing here is we're actually manipulating several variables and monitoring several variables at once. It's time, it's progression of that time over time. It's rest days, it's monitoring soreness during a run and after a run. And if we get a little soreness during the run, we're probably okay as long as it doesn't persist into the next run, right? We got to normalize some of that too. Talk to me a little bit about, how do you talk to an athlete about understanding soreness versus pain? That's a really hard thing on the individual level.
Especially when you've taken these people from not running. So if they've been running enough to get a stress injury or IT band syndrome or something like that, they're not having soreness when they run. Their muscles don't get sore from day to day unless they do some really big, hill workout or something really fast. But we just don't feel sore when we're doing that very commonly. And so you have to be able to say soreness is what you experience when you do something for the day and it's kind of global. It's not focused. It's not one specific spot. Pain is something that you feel the next day. And really specifically, I'm into that next day. If you wake up the next morning and you put your foot down and you go, ooh, that hurts. You did something too much the day before, or something that's making you limp, something that's making you do something asymmetric while you run. So I'm running along and I feel like I'm pretty good and I'm listening and my breathing's going pretty good. And then 2 miles into it, my breathing's hard to do. My rhythm's off. I'm starting to sound different on one side. If I look at my shadow, I'm limping. Sometimes I feel the limp. It's time to shut that down because you're progressing too hard at that point in time. So those are kind of the things that I try to educate people about, especially in that middle, appointment when I go, look, you're getting ready to run. Here's the run protocol that we're going to do. Here's the things to look for.
Yeah, absolutely. Now we've talked a lot specifically about rehabbing a runner's injury and returning them that way. What about like just a field sport like soccer? How would that look?
Yeah, and so, it's very similar. And the reason I say that is, one of the things that my post-surgical patients do that do running and twisting and cutting and turning is they use running for the rhythm that helps them get back to their sprinting, cutting sport. They need to have the rhythm of their muscles that they count on to be able to then cut off that leg or stop and plant off that leg. Many of those people are dealing with post-surgical kinds of things. And so I do similar things. I think global movement patterns first. I try to make a lot of closed chain kinetic exercises part of their process because we know that they're going to need that when they go and stomp on their foot and try to change directions. I try to build on that neuromuscular control while they're down, especially in those couple of weeks where they're shut down before we have them running. But boy, the bike to elliptical to the anti-gravity treadmills is pretty similar for those people. I've just tried to think about them and give them maybe some additional things that they can be working on, like closed chain kinetic exercises. We can be doing those very slow and in very controlled settings that they're not going to hurt themselves again, but they're starting to refire those muscles in the order that they're supposed to be fired.
I love that. So really, it's the same process. I want people to hear that returning to running is returning to running in some respects, right? Now there will be additional things that we'll do for a field athlete that we don't necessarily do with a runner who's unidirectional. But with that said, man, getting a runner to do some different things outside of their normal motor program, like cutting and things like that, that can be a really big, challenging deal, can't it?
And it's challenging for us as clinicians, but also super valuable for the athletes. And an example that I can think of is an elite marathoner that had a decently dangerous stress injury, and she had to take time off for that. And that didn't leave us very much time to get her ready for the race that she had to prepare for. And it's really funny. What I did is I stepped back and I let her be an athlete, is the way we worded it. Is I let her go back and play basketball outside, and I let her, play racquetball and lots of stuff where it was cutting and twisting and turning, but it was loading those bones in different ways. And I do think that our running athletes can benefit from what I would call, trying to adapt to a different sport. It's going to load those bones in new ways. It's going to ask those muscles to work in different ways that will only benefit them when they go back to just running straight ahead, because running eventually just becomes a stupid sport where we do the same thing repetitively over and over and over, and they benefit from twisting and turning activities.
One thing that makes me think of is, we talked about, looking at getting someone on a cross training protocol and getting that to a certain level before we turn to running. Where does a certain amount of walking fit into that? Because I know, for example, with ACL reconstructions, I always like to have my athletes be able to walk a mile or two before I'm even going to start them to run, because it just a lower level of loading, but a higher intensity. Does that factor into things at all?
It sure does. It can be that day off. It can be your day 3 on the running progression.
Okay.
Because there's something about that rhythm that I like as well. But it can also be, early on. So if you've got a IT band syndrome and we're just shutting you down because it hurts, it's not a bad time to just say, put your shoes on and let's go for a walk. Let's go do some sustained repetitive motion. Now, I really feel strongly that I need them to do their corrections right before they go do that. So if they have a reason for their IT band, like their glute isn't firing and so they can't externally and extend their hip very well, boy, they better do that activation for me and get that thing strong before they go walk a mile, because it's still going to rub. That IT band's going to rub with every step. But that gives them a great opportunity to say, I'm going to do my exercises, and then I'm going to go for a 20-minute walk, and I'm doing something. And that is so valuable for them. It's also good for the bone if it's a bone healing issue.
Yeah, absolutely. And probably hitting those correctives afterwards to make sure that whatever they didn't cause some lasting effects there. So that's awesome. Well, to wrap things up, what final words of wisdom or inspiration would you like to leave with the audience that's listening to us today?
So I feel like if I could leave this with a couple things, the first is runners are super variable because they are individuals. They have an individual injury or overuse injury. And because of that, they need individualized programs. There's not a very specific thing that I can say, like the 45 minutes we talk about, those are not rigid rules. Those are just kind of my individual examples that then I would take to the people. You have to build it individually for them. You have to consider what their goal is, but you also have to consider what they brought you. If they're not very fit right now, you can't push them very hard and get through that. And so that's something that you have to consider, is how much fitness they have when they get in. The last is, athletes are going to hit that barrier. You have to hit that barrier at some point in time. And I just tell them that they're going to do it. Like you said, I don't set it up as a negative or a failure. I set them up as, this is going to happen and this is how we're going to respond to it.
Oh, that's awesome. Well, fantastic. This has been so much fun to have this discussion. And I recognize that, man, there's so much more we could talk about, but that's all the time we have for today. Thanks again, Dr. Todd Arnold. I would so appreciate you just working through this return to running concept and the things we need to think about and those case scenarios really help take it home, where we have some actionable takeaways to understand exactly what we need to do with our athletes. So thank you so much, Todd. I really appreciate it.
Thanks for having me.
Awesome. Well, until next time, let's keep building the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you would like to see addressed on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcast@medbridge.com. See you next time.